Hello, everyone. Are you able to hear me okay? Okay, thank you for replying. We'll wait a couple of minutes before starting. I think people are still joining in. Okay, so I'll give a little introduction about myself. So I'm Arushi. I'm currently training in here in Queensland, Australia. I know I haven't taken a class for you guys before. So today I'll be talking about rheumatology. Rheumatology is a important topic for AMC 1. We get quite a lot of questions from it, and it's more like, either you know the answer or you don't know the answer. So there's not a lot that you might remember if you haven't read about it before. So revision of rheumatology is very, very important. Okay, so we're 3 minutes in. I might just wait for a minute more because I can see people still adding on, and then we can begin. Let me know if anytime during the presentation, either you can't hear me properly or there's any issue with the slides, so we can fix it as soon as possible. All right, so are you all guys ready to begin? I'm having a look at the chat box too. So, if there's any concern, you can write down over there. Sure. Now, let's start. So this evening, we're going to talk about rheumatology. There are 4 main subheadings into which rheumatology is divided. So it's arthritis. Now, there are different types of arthritis. It's osteoarthritis, rheumatoid arthritis, and spondyloarthritis. Spondylo itself is divided into furthermore. So once we're done with arthritis, we'll move on to crystal disease. Crystal diseases are gout and pseudogout. Following that, we'll do some inflammatory connective tissue diseases. So that's SLE, Sjogren's syndrome, sclerosis, and myositis. And the last one that we'll talk about is vasculitis. So these are the 4 main subcategories into which rheumatology questions will come from. Okay, so let's start with arthritis first. It seems like a very easy topic, and honestly, it is, but it's quite high yield. So don't take it, don't take it that you're not going to read about it. You're going to get a lot of questions from this. Okay, so under arthritis, we have osteoarthritis. So what exactly is osteoarthritis? It's a non-inflammatory type of arthritis. So it's more like a wear and tear disease, and it's the most common form of arthritis in the world. It's usually seen in the elderly population, and it's more common in women when compared to men. Now, osteoarthritis tends to affect all the joints of the hand, which includes your proximal interphalangeal joint, your distal interphalangeal joint, also your carpometacarpal joints. All right. So what are the pathological changes that you see in the joints? So there'll be joint erosions, there'll be sclerosis, the patient will come with stiffness. These are some of the common symptoms. Now, sorry, I'm just trying to move the slide. Yeah. Okay, now if you guys have a look at these 2 images, you can see, are you able to see my cursor? Just reply yes in the chat box if you can see my cursor as well. Okay, thank you. So you can see in these images that there are some swellings here of the DIP, and there's some swelling here of the PIP. So over here for the DIP, I've mentioned these are the Herbinden's node. Does anybody know what the swelling of the PIP in osteoarthritis is called as? If you guys know, you can drop in the chat box. Yes, Nadira, that's correct. These are the Bouchard's node. So how we used to remember it is that BP, so Bouchard's is PIP, proximal, so that's BP, and HD, that's Herbinden's, is distal. So if that's something that works for you, BP and HD, that's how you remember this. So from this slide, one important thing for you to remember is that we have these notes in osteoarthritis affecting PIP and DIP. To remember is that it's the most common arthritis in the world. Third thing to remember, it's non-inflammatory. It's a wear and tear type of disease. Okay. Now, there are two types, primary, which is more likely hereditary, and secondary, which comes after either trauma or some joint infection or some other connective tissue conditions. We've already mentioned that it's more common in elderly, in females. Other important factor is it's more common in people who are obese and do certain kind of occupation, which involves more of, handwork. Also, it's seen more commonly in people of the lower socioeconomic status. And I do remember that once they asked what are the risk factors of osteoarthritis, and one of the options was lower socioeconomic factor, and that was the correct answer. So it's kind of silly, but then yes, it's something for you to remember because it's been, questioned previously. Now, this is important. This is what differentiates osteoarthritis from other inflammatory arthritis. Now, because it's a wear and tear kind of disease, so it's obvious that it will come more when we use our bones more, and it'll improve with rest. So it's, aggravated by use, and it improves with rest. And people with osteoarthritis will mostly see that the pain is more towards the end of the day. All right. Now, sometimes you might get a question that so-and-so 80-year-old lady coming in with pain in her joints, which is increased by the evening, but she also gets some morning stiffness, which usually 2 hours. Which usually lasts for like 20 minutes or so. So if they're getting morning stiffness, which is less than 30 minutes, that could also suggest osteoarthritis. Okay, now we looked at 2 signs already on the previous slide. The other signs to remember is that the swellings are hard, bony swellings. Then the patient might get some crepitus. There can be some joint deformities, and there can be associated muscle weakness. Okay. Okay, so basically the thing to remember from this slide is that pain with activity, pain improves with rest, and morning stiffness, less than 30 minutes. Now, what investigations will you do? So some of the basic one will be an X-ray, which is the test of choice. Now, what will the X-ray show you? X-ray will show you some joint space narrowing. So as you can see in this image, there's narrowing of the joint space. It's written as reduced joint space. Then there is sclerosis, the white line there, that's sclerosis. And then there's formation of new bone there, that's just the osteophyte. So what's really happening is the bones are rubbing against each other, wear and tear. When that happens, there's reduction in space between the 2 bones, and there's new bone formation. So there's sclerosis, that's the white line, and the new bone that's forming is the osteophyte right over here. Okay, you might get, you might be asked these points which are seen in the chest X-ray in the form of a question. So it's important to remember what is an X-ray in osteoarthritis. This is just another picture depicting similar findings. All right, now management. So I think most of you know there's no cure as such for this condition, but there are some things we can do to prevent this from developing, and there are some things we can do to relieve the symptoms. Now, prevention, increased physical activity, weight loss, some physiotherapy, these are some preventive steps that one can take. And what are the symptom control measures? It's regular paracetamol. So the best treatment you can give is regular paracetamol, not PRN paracetamol. Other options can be corticosteroids injection, but then again, these injections are like short-lived, so you can't give it as a long-term treatment. If somebody is in severe pain and nothing, no analgesia has worked for them, then they can consider a steroid injection, which works for around 2 or 3 months, and then after a period of time, they might need one more injection. Besides that, there has been some research that duloxetine is helpful. Then there are always some surgical options that we can opt for as well. Okay. Sorry, my slides are just taking some time to move on to the next one for some reason. Okay. Right, so we're done with the first subtopic, which is osteoarthritis. Now we're going to talk about rheumatoid arthritis. Now, this is a different type of arthritis. It's not wear and tear. It's inflammatory arthritis, and it's an autoimmune disease. Now, because it's an autoimmune disease, it affects, other parts as well. Okay, just like osteoarthritis, rheumatoid is also more common in female. And there has been some genetic link associated with HLA-DR4. Now, some ways in which we can prevent this from occurring is stopping smoking, weight reduction. These are few things. Now, unlike osteoarthritis, rheumatoid arthritis, the prognosis is very good if we detect it early. Second, we refer the patient to a rheumatologist. And third, the rheumatologist starts DMARDs early. Okay, so there is a treatment for rheumatoid arthritis. Now, clinical features is exactly opposite to osteoarthritis. So in osteoarthritis, we learned that it's more with activity. Rheumatoid arthritis is relieved with activity. In rheumatoid arthritis, morning stiffness is present. Morning stiffness is usually more than 30 minutes in rheumatoid arthritis. Now, what are the signs? So signs, we'll see that it is symmetrical inflammation. So we'll see these symmetrical swellings. Most commonly, it affects your metacarpophalangeal joint as well as your proximal interphalangeal joint. And sometimes it also affects the carpometacarpal joint. Now you'll notice here, the one joint that is spared is your distal interphalangeal. This joint is not involved in rheumatoid arthritis. Almost always it's not involved. All right. Again, this is something that's very often tested. They'll give you a couple of joints and this one is not involved in rheumatoid arthritis. So make sure it's DIP, which is not involved. Now, how in osteoarthritis, we had these two different signs that we could see on our hands, which was, BP and HD. Here, there are a couple of signs that we can see, so a couple of deformities that we can see. So let me get the image up. Yeah. All right, the first deformity is swan neck. So that's the swan neck deformity. Then we have ulnar deviation of the hand. Then we have some Butner's deformity. So these are some of the deformities that are seen in the later or advanced stages of rheumatoid arthritis. Okay. This is just a bit more elaborate, elaborate points as to what should be there in the clinical features in order to diagnose rheumatoid arthritis. So it says basically the same things, that there have to be swelling in 5 or more joint. The symptoms need to be longer than 6 weeks. And then there has to be positive bilateral compression tenderness on the metatarsophalangeal joint. So the metatarsophalangeal joint are another set of joints that can have inflammation in rheumatoid arthritis besides your hand joints. There has to be early morning stiffness. Then we need to do some tests like RF and anti-CCP, which would be positive. And then we can do some x-rays. So these are basically all the investigations, the symptoms, and the sign that we must consider before diagnosing anyone with RA. One important thing is that there could be a positive family history as well. Okay. Now, because it's an autoimmune condition, it's an autoimmune condition, it can affect other parts of the body besides, the bones. So these are some of the common and uncommon areas that can be affected. So it could be your lungs, ILD, it could be eyes, it could cause keratoconjunctivitis, Zika. Sometimes it can cause multiple organs. For example, in Felty syndrome, there's spleen that is involved, hypersplenism, there are blood cells that are involved, causing neutropenia, as well as bones involved, with RA. Okay, then. Now, how do we investigate RA? We ran through a couple of them already in the previous slide. One was X-ray, and the other one was some blood test. Because it's inflammatory condition, so CRP would be elevated. It's common to find anemia, normocytic normochromic anemia, full blood count. Serology-wise, there are two tests that you can do. First one is RF, rheumatoid factor. Now, with rheumatoid factor, it is a sensitive test, but it's not that specific. So to be more specific, you have to do anti-CCP. Okay, that's highly specific for RA. And mostly rheumatologists will ask you that, okay, if rheumatoid factor is positive, it doesn't always mean that it's RA. So make sure you do anti-CCP as well. Now, what will we see on the X-ray? Now, on the X-ray, we'll see erosion of the joint margin. We're not going to see any osteophytes here. We're not going to see any sclerosis here. We might see subluxation of the joint. Because of the erosion, there has been inflammation, there has been erosion, there could be subluxation of the joint, there could be cyst formation, but there's no sclerosis that's happening. Okay. Now, management, in the first slide itself, we went through that, the prognosis can be very good if we refer these patients early and if these patients are started on DMARDs. So that's what we're talking about in management. We can use NSAIDs as first line to reduce the pain, but definitive management would be with DMARD. And the first line in DMARD is methotrexate. But if somebody is pregnant, then we need to decide about hydroxychloroquine in those patients. Other common things is ensure we talk about weight loss, exercise, stopping smoking. These are some things that we have to advise all our patients. All right, guys, can you let me know if you think I'm going too fast or too slow? Just let me know on the chat section. Okay. Okay, thanks for replying again. Looks like it's all good. So we've covered OA, we've covered RA. Now we're going into spondyloarthritis. So spondyloarthritis is again divided into a couple of more categories, but we'll talk about them in the next slide. Just like an overview. So again, this is inflammatory, just like RA, but what are the differences? In this RF, that is rheumatoid factor, is negative. In this HLA-D27 will be more positive. And the other thing that we'll see is that it has more of tendon involvement, which is enthesopathy. So, plantar fasciitis, Achilles tendinitis, these are some things that we'll commonly see under this category. So we'll start with AS, which is ankylosing spondylitis. Okay, so with AS, again, it's a gradual onset. It usually occurs in the younger section of population, that is before the age of 45. The symptoms should be lasting for 3 months or longer. Again, these patients, because it's inflammatory disease, so morning stiffness will be present. Also, we'll see that these patients will feel better after using some anti-inflammatory medicines like NSAIDs. Okay. Oh, come on. Sorry. Okay, that took time to come up. So these are the 3 types of spondyloarthropathies that we're going to talk about. So AS, then reactive arthritis, and psoriatic arthritis. There's a 4th one as well, which is not really tested on AMC 1. It's mostly IBD-related arthritis. So I'm not going to talk about that. It's not required for this exam as such. All right. Now, for AS, what are the clinical features? So AS mostly affects your sacroiliac joint, your spine. Okay, there will be morning stiffness. Now there's limited lumbar movement of the spine. So when we ask the patient to bend down, usually the distance is supposed to increase more than 5 centimeters, as you can see on this image. But if it's less than 5 centimeters, so it's more suggestive of a spine involvement or AS. So it's not a very specific test, but it's just one of the clinical features that you can look at when diagnosing AS. Sorry, somebody is asking whether AS is not important for AMC. No, AS is important for AMC. I was just talking about the fourth category of spondyloarthropathy, which is IBD associated arthritis. That is not important. So this is important. All right. So moving back to this, what else? We'll see that the chest expansion will be limited in these patients. All right. Now, these are some of the clinical features that predict poor prognosis in AS. So if the hip joint is involved, that's poor prognosis. If somebody younger than 16 years, gets these symptoms and is diagnosed of AS, that's poor prognosis. If we see that there's dactylitis, which is inflammation of the whole finger or toe, that's again poor prognosis. And if the patient is not responding to anti-inflammatory like NSAIDs, that again is poor prognosis. Now this part, what are the features that predict poor prognosis, is sometimes tested on AMC. So it's good if you remember this. All right. Now, how do you diagnose? Again, CRP, ESR will be high because it's an inflammatory condition. Serology-wise, there's not going to be any RF factor. There's not going to be anti-CCP, but we're going to find HLA-B27 antigen, which is positive. Now, on X-ray, what are we going to see? We learned already it's affecting the spine and the sacroiliac joints more. So we're going to see bamboo spine, which is a straightening of the spine, as you can see here. So that's one thing we can see on the X-ray. But X-ray is not the most accurate test to diagnose this condition. The most accurate will be MRI of the lumbosacral spine. Okay. All right. Now, how do you manage it? Management is similar to, the RA, because it's an inflammatory arthritis again. So we're going to use NSAIDs. We're going to use DMARDs, but the type of DMARDs we're going to use in AS are slightly different. Methotrexate does not help in AS. Methotrexate does not help with the spine arthritis. So just make sure that you know this. And corticosteroids, again, don't help in AS. There are other biological DMARDs that we can use to treat patients with AS. All right, so we learned about the first type of spondyloarthritis, which was ankylosing arthritis. Then the next one will be reactive arthritis. Now, reactive arthritis usually develops after some infection. So it's the development of non-septic arthritis and sacroiliitis after infection, like a urogenital infection or a GI infection. The most common one would be Chlamydia trachomatis. So this is the most common organism that we see in patients who develop reactive arthritis. Now, what joints does it affect? It affects the larger joints more, and it's seen that this arthritis starts 1 to 3 weeks after getting the infection. Now, besides affecting the joints, it can also affect the eyes with uveitis or conjunctivitis, and it can affect your fingers and cause dactylitis. Now, this is a common triad that many of you might know, that with reactive arthritis, a patient can't see because they have uveitis or conjunctivitis, because if it's after a GI infection, they're having dysuria, and can't climb a tree because of the arthritis. Okay. Now, management-wise, management will be NSAIDs. We should give some antibiotic if there's ongoing infection. Steroids can be used in severe presentation, and DMARDs are used if somebody chronically has symptoms. Okay, now psoriatic arthritis is the third type. In psoriatic arthritis, there's inflammatory arthropathy, which is accompanied with some skin changes and some nail changes. So we can see these patches of psoriasis, which is affecting your skin, also your nails. And the joints that it involves, the sacroiliac joint and the DIP joint. Now, just for a recap, can someone tell me in the chat box which arthritis does not involve DIP? Like in the next 2 or 3 seconds, please. Okay, thank you. That's good. So, oh, I think you guys misunderstood my question. My question was, which arthritis does not involve DIP? Yes, so RA does not involve DIP. Okay, that's good. Looks like you guys are listening, so that's a good sign for me. All right, so psoriatic arthritis involves DIP, involves the sacroiliac joint. So besides joint involvement, you'll see these nail changes, nail pitting. You'll see some skin changes, which can happen mostly in the extensor surfaces rather than the flexor. And management, again, would be NSAIDs, DMARDs, and sometimes anti-TNF factors. But most likely, what will be tested would be diagnosis of psoriatic arthritis rather than the management. Okay, it's important that you're able to diagnose it depending on what all, what all joints are involved, what all other organs are involved. It's important for you to know how to diagnose. And if you guys have noticed, the treatment for all, that is AS, reactive arthritis, psoriatic arthritis, the first treatment we give for pain is NSAIDs, followed by DMARDs. The only difference we noticed was that in your last one, is AS, we're not giving methotrexate because methotrexate does not help with the spinal inflammation. Okay? Otherwise, it's almost the same. Is it clear so far that we're going to move on to crystal disease after this? If you can just say a yes or no, and then we'll move on to crystal disease. Okay, thank you. All right, so the next category will be crystal disease. We have gout and pseudogout. So let's talk about gout first. So gout happens because of deposition of monosodium urate crystals. So these are just crystals which are depositing. Mostly it happens, the large toe or the first metatarsophalangeal joint. Now, some risk factors that can make people more likely to have gout is if there's a family history, then they use certain drugs that inhibit the excretion of uric acid, or they're consuming certain types of food, or they're taking more alcohol, or they have some underlying conditions like diabetes, hypertension, dyslipidemia, CKD, or obesity. Now, do you guys know what are actually purine-rich foods? Because you might get it in a question that so-and-so eats this food, and now what do you think the diagnosis is? So you should know what purine-rich food actually means. Does anybody know that? Red meat? That's correct. Red meat. Now, what is red meat? Sometimes they might not try red meats, things like pork, beef, these are all red meats. So this is something you should know. Now, drugs that inhibit renal excretion of uric acid. What are these drugs? Can you tell me 1 or 2 drugs that can do that? Yep. So thiazide, that's correct. So diuretics like thiazide can do that. And what else? Furosemide can do that. So these are some of the drugs, that can increase the risk of getting gout. Okay, moving on. So what are the clinical features? So it's usually monoarticular. It'll affect your big toe. It happens quickly rather than the other arthritis that we've talked about so far. Gout will happen very rapidly. It'll be very painful, red, swollen. Sometimes the patient will appear like he's having septic arthritis because there'll be fever, there'll be increased white cells. But you need to be very careful how to differentiate between septic arthritis and gout in a clinical setting. Okay, now what happens if we don't treat gout and the patient is getting attacks? If patient is getting recurrent attacks, then there could be a chance that it can affect kidney and cause CKD. There are the 4 stages of gout. It starts as asymptomatic hyperuricemia, then acute gouty arthritis. This is what patients usually come in with. Then between acute and chronic, there's intercritical gout, and then we have chronic tophaceous gout, 5 forms. So what are the investigations we will do to diagnose gout? So first one we'll do in blood, which will be your uric acid, which will be high. When you do X-ray, you'll see punched out lesions. It's important to remember the finding for all kinds of arthritis. Then when you aspirate the synovial fluid, you'll see something like this. So it's needle-shaped crystals, and they're negatively bifringent. Okay, and because you're aspirating synovial fluid, you'll also be sending it for microscopic culture, and that'll probably be negative. So you've ruled out septic arthritis as well. Okay, in terms of management, so on the first slide of gout, we discussed for the risk factor. So general measure will be avoid all those risk factors. Okay, how do you treat the acute attack? So the first line will be NSAIDs. And if patient can't take NSAIDs, then you try steroids. All right, and then if both NSAIDs and steroids are ineffective, then you go with colchicine. One thing that you need to remember with colchicine, that it has the strongest evidence to work as a prophylactic drug, against these attacks of gout flare. Okay, so this was about acute attack of gout. Now, what happens between attacks? So, in between attack, there are 3 drugs that we could consider. So first one is allopurinol. Allopurinol, what it does is that it reduces uric acid production. Can somebody tell me how it reduces uric acid production in 3 words? What's the mechanism of action? Okay, nobody is typing. That's all right. So it's a xanthine oxidase inhibitor, and that's how it reduces uric acid production. Now, you need to start allopurinol at least 2 to 6 weeks after an acute attack. Okay, now if somebody can't take allopurinol, the other drug that we can use is febuxostat. One thing we need to be careful is that we should avoid using febuxostat in patients who already have a kidney disease or a previous CAD, like a coronary disease. And the third thing you need to remember is if somebody is taking azathioprine and mercaptopurine, don't give febuxostat because it can cause bone marrow toxicity. Okay. Now, the third drug that we can use is probenecid. Probenecid does not reduce uric acid itself. It works differently. It removes excess uric acid from the body. Now, if it's removing excess uric acid for the body, you need to use it cautiously in patients who already have urate nephrolithiasis. So these make sure that you have this in mind, that when you can use allopurinol, when can you use febuxostat, and what are the contraindications. Now, for someone who already has chronic gout, already has a tophi, the best treatment is with allopurinol. And surgery can be one option if the joint is extremely painful and pharmacological measures working. Okay, so that was about treatment of gout. We discussed about acute, in between attack, as well as chronic. Now we will move on to pseudogout. Pseudogout, like in gout, we had uric acid crystals. Over here, we're having CPPD, calcium pyrophosphate crystals. Over here, like it mostly affects these joints which are already weak, which are already osteoarthritic. So it happens more in people who are elderly. All right. Some of the joints that are commonly affected would be your knees and wrist, and second and third metacarpophalangeal joint. Now, how will you investigate? When you do X-ray, you'll see calcification of the articular cartilage. When you'll aspirate the fluid, you'll see rhomboid crystals, rhomboid like these, and you'll see positive bifringent crystals. Now, in gout, it was needle shape and it was negative. In pseudogout, it's rhomboid and it's positive. Treatment would be NSAIDs as the first line, and the best treatment is actually steroids. Okay, so we've completed the crystal disease, which was gout and pseudogout. So now we are moving on to connective tissue disorders. Connective tissue disorders have a few more diseases under them, as I've mentioned over here. Excuse me. It's an autoimmune response. It's an autoimmune disease again. We'll start with the first one. So first one is SLE. Systemic lupus erythematosus is the most common type of connective tissue disorder. It involves multiple organs, but the most common presentation or the most common symptom that the patient will come in with will be arthritis. Okay, now because it involves multiple organs and there can be a lot of symptoms and signs that one can imagine, so there is this mnemonic, which is sometimes helpful. Okay, so that's SOAP Brain MD. If we have any 4 out of these 11, then it's more suggestive of SLE. So serositis, so it's inflammation of pericardium or the lung, so pleurisy, the pleura. Oral ulcers, it's important to remember that these ulcers are painless, because later on we'll discuss about other conditions which can cause painful ulcers, but in SLE, the ulcers are painless. Arthritis in SLE is not deforming, okay? Photosensitivity. Then blood disorders, we can see that there can be a decrease in the cell count in any of the cell lines. So it can be anemia, it can be thrombocytopenia, or it could be leukopenia. Now, renal involvement, we'll see proteinuria. Serology-wise, SLE patients will be ALA positive. Immunological changes, again, we'll have anti-dsDNA positive, anti-Smith antibodies positive. So these are the 3 serological findings that we can find in SLE. Neurological changes, patients will have headache and seizure. Then there's malar rash and discoid rash. So this image over here, the butterfly rash, that's the malar rash, and these are the discoid rash. So if I were to remember SLE findings, without remembering SOAP Brain MD, I would remember is that there's joints involved, so it's inflammation of the joints, arthritis. There could be inflammation of the lungs, there could be inflammation of the heart, then there can be some skin changes, so there are rashes like malar and discoid rash. There can be kidney involvement, so inflammation around the kidneys as well. So if you think about it, it's inflammation of a lot of linings in the body, okay? Because I think in exam settings, it's difficult to remember each and everything. So just get an overall picture, get the points that you need to remember to diagnose a condition for an exam point of view. Okay. Now, investigation will find that ESR or CRP will be high. Serology, as we already discussed, it's ANA, anti-dsDNA, and anti-Smith antibody. In this, what we need to remember is ANA is sensitive. It is the first test, but it's not specific. Specific test will be anti-dsDNA. Okay, so anti-Smith antibody is only done if anti-dsDNA was negative and you're suspecting SLE, and that's when you do anti-Smith antibody to confirm the diagnosis. But even in this case, the most accurate test will be biopsy, skin biopsy. Okay, so when you get a question, make sure you read what are they asking. Are they asking for the first test to be done? So in that case, it's going to be ANA. Are they asking for the most accurate test? And you have skin biopsy as one of the options, it's going to be skin biopsy. If they're asking for the most accurate test, but you don't have skin biopsy as an option, but you have anti-dsDNA or anti-Smith antibody as an option, so that's going to be the answer. So just, be very careful reading what are they asking, what are the options, and then pick accordingly. Okay, treatment-wise, if it's mild SLE, that means it's only joint involvement, we're going to give NSAIDs. Moderate means there's joint involvement and skin involvement. So we either have malar rash or we have discoid rash. So in that case, we give hydroxychloroquine. One side effects of hydroxychloroquine is ocular toxicity. Now, if it's severe SLE, severe means it's a systemic disease. It's spread beyond the joints and beyond the skin. In that case, we need to give steroids. And we can give some immunosuppressive drugs like methotrexate. So we need to divide the treatment into mild, moderate, severe. It depends on what parts of the body have been involved already. So that's SLE. The next one we're going to talk about is scleroderma. Now with scleroderma, it mainly affects the skin. One change we're going to see is the Raynaud's phenomena. We'll talk about Raynaud's phenomena a bit more, bit further in the slide. So skin, Raynaud's phenomena, the other soft tissues it can involve is the fingers. It can cause sausage-like fingers. Again, with scleroderma, it's more common in females. There are three variants of scleroderma. So limited cutaneous disease, it mostly involves the Crest syndrome. Crest syndrome is, okay, let's talk about it with the image. So we have limited cutaneous, we have diffuse cutaneous. So if I were to explain this in simple terms, limited cutaneous involves bones below the elbow and below the knee only. But diffuse cutaneous would involve even above the elbow and above the knees as well. So that's how you differentiate. Okay. So clinical features, Raynaud's phenomena, stiffness of the fingers, tightness of the chest, which is known as a Roman breastplate, the image that here, bird-like faces, puckered mouth, the image that you can see here. Okay, there can be malabsorption. Then if there's systemic involvement, we can get pulmonary hypertension, pericarditis. So this is the Crest syndrome image that I was talking about. I find this really helpful. So Crest, C is for calcinosis. We can see some calcium deposits in the skin. R is for Raynaud's phenomena. E for esophageal dysfunction. So there can be acid reflux. There can be malabsorption. Then S is sclerodactyly. So it can be thickening of the fingers, sausage-like fingers. And T is telangiectasia, which is dilatation of the small capillaries, which cause these red dot-like signs. Okay, so this one is showing calcinosis, and you can see similar calcinosis even on the X-ray, the white bits. These are all calcinosis. Okay, and this one you can see it's showing sausage-like fingers. You can see the tightened, glossy skin. So that's sclerodactyly. And you can see the red spots over here. These are all telangiectasias. Investigation-wise, ESR will be high. It can show anemia. ANA would be positive, but again, it's a sensitive test, not a specific one. ANA, if you remember, was also positive in SLE. Okay. Now in SLE, what else was positive? Anti-dsDNA and anti-Smith antibody. But here in scleroderma, we have anti-topoisomerase antibody, also known as scleroderma 70 antibody, and anti-centromere antibodies, which are positive. Sometimes they might specifically ask for Crest syndrome, that which antibody would be positive. So in that case, please pick anti-centromere antibody. Just remember it as C and C. Okay. So in Crest syndrome specifically, don't pick the topoisomerase one. Okay, the other investigation that we can do is skin biopsy. Just in case somebody wants a revision of Raynaud's phenomena. So in Raynaud's phenomena, what happens? We get white, blue, and then red, as we can see in this image. And what medication do we give? We can give calcium channel blockers, or we can give nitrates. And what preventive measures or general measures we can take? Stop smoking. We can give them something warm, like heat packs or gloves, something like that. Okay, so that's about Raynaud's phenomena. Okay, so we have spoken about SLE. We have spoken about scleroderma. Now we're going to talk about Sjogren's syndrome. So Sjogren's syndrome is the most common inflammatory connective tissue disease after rheumatoid arthritis. Okay, it's more common in female. Again, it could be primary or could be secondary because of other connective tissue disorders. One thing to remember is that with Sjogren's syndrome, there's a very high association of non-Hodgkin's lymphoma. And they can sometimes question you that the vignette of the question would have that, patient has a background of non-Hodgkin lymphoma and now has presented with this. What is your diagnosis? So it's something to remember for exam point of view. So what are the clinical features of Sjogren's syndrome? So it's basically dryness everywhere. Okay, so there's going to be dry eyes, dry mouth, dry vagina. There's going to be dryness of the secretions of the trachea. So it's going to cause cough, hoarseness of voice. There'll be chances of increased dental caries. And there's obviously going to be arthritis and joint pain. Again, one thing to remember that these are non-erosive arthritis. Even in SLE, we learned that the arthritis does not cause deformity. Okay. Now, investigation. ANA would definitely be positive, but what is the specific serology that would be positive? That's anti-Rho and anti-lambda antibodies. These are the ones which are going to be positive. But confirmatory or most accurate diagnosis will come with a biopsy. Okay, in terms of treatment, we can give NSAIDs for the arthritis, but for other things, eye involvement, we need to get, refer to an ophthalmologist for that treatment. And because it's affecting other parts of the body, so we need to refer, to that specific specialist for the treatment. Okay, so next up, we have antiphospholipid syndrome. Now, guys, have you been doing okay? I know rheumatology has so many markers and so many similar conditions with mild changes, so it can be quite tricky at times to follow a lecture. But just let me know if you guys have any questions or want me to do a quick revision before going forward, or we can do one at the end if that's fine. Okay. Are you guys still awake? Nobody's typing? Okay, sounds good. Thank you. Okay, so antiphospholipid syndrome. So antiphospholipid syndrome is, again, a systemic autoimmune condition. So in this condition, it's different from the other conditions that we discussed about. Here, we are getting clots. So there's going to be thromboembolism, or they're going to be pregnancy-related complication. And this is associated with antiphospholipid antibodies. Okay, so antiphospholipid syndrome, it cannot be diagnosed with just an antiphospholipid antibody being positive. We need other things. So one thing we need is at least one clinical manifestation, either in the form of thrombosis, like either pulmonary embolism, or in the form of obstetric finding, like either there's a miscarriage or a threatened abortion, things like that. Okay, and we need positive APL antibody, or at least 2 occasions 12 weeks apart. So we can't just diagnose somebody with antiphospholipid syndrome just because the APL antibody was positive. Now, for somebody to be diagnosed as an obstetric antiphospholipid syndrome, that lady should have had 3 or more early miscarriages. Early miscarriages means it was less than 10 weeks gestation. Okay. All right. Move on to the next slide. Investigation in terms of serology, we'll have antiphospholipid antibodies positive, but the more specific one are going to be anticardiolipin and anti-beta-2 GP1 antibodies. Now, in terms of treatment, when somebody has a history of obstetric antiphospholipid syndrome, we try to advise those patients, or actually we prescribe low dose of aspirin, and we ask them to take it all throughout pregnancy and as well as 6 to 12 weeks postpartum. And along with low dose aspirin, it's also advisable to give some low molecular weight heparin. Okay, and for somebody who have thrombotic antiphospholipid syndrome, for those patients, we prescribe lifelong anticoagulation with warfarin. Okay. All right, so that was antiphospholipid syndrome. Now we'll move on to myositis. So myositis can be 2 types. It could either be dermatomyositis. So dermatomyositis usually only involves skin. Most likely seen, children can be affected. Sorry, not most likely seen in children, but children can be affected. But polymyositis, it's only a muscle disease, does not involve the skin, and usually seen in middle age and above, not in children. Okay, now dermatomyositis. So dermatomyositis, we learned that it can affect the skin. So how does it affect the skin? It affects the skin in the form of rash, which is known as helioptero rash. Everyone has a different way of pronouncing that, but almost looks like rounded rash, which are violet colors, mostly around the eyes or the forehead or cheeks. And these are photosensitive, so it worsens in exposure to sunlight. And the other way in which it affects the skin is through these nodules on the knuckles. There are Gottron's violet color papules. It can also occur in knees and elbows. And PM, which is polymyositis, that usually affects the proximal muscles of the body. Now, if somebody can tell me what are the proximal muscles, I mean, I'm sure you guys know that, but sometimes they give you like a vignette and they explain that the patient has difficulty in doing certain tasks. So in that case, you need to know what muscles are involved and what might the patient have. So somebody has written biceps, okay. And what about the lower limbs? Mm-hmm. Yeah, that's correct. Unable to comb hair or unable to get up from their chair. These are some common clinical questions that you'll get in AMC if you want to diagnose this condition. Oh, sometimes you also are unable to put shirt on. So things like that, anything that involves the proximal muscle. Okay, so what investigations will we do? So we'll check ESR, okay, we'll check CK, aldolase. So these are some of the serological tests which we can do. But again, confirmatory or the most accurate one will come from the muscle biopsy. All right. In terms of treatment, it's steroids for myositis. We can try other treatments like immunoglobulins and immunosuppressive agents as well. Okay, I think we've talked about a lot of topics. And I think before we move on to vasculitis, maybe we should take like a 10-minute break. What do you guys think? Okay, somebody's writing good. 10 minutes break. So let's be back in 10 minutes and then we can talk about vasculitis. If you want, you can go through, if you were making notes, so just go through what we've discussed so far, because I do understand that a lot of these topics are related and it can be difficult to answer questions on the exam. Can you please share PDF in the group? Yeah, sure. I'll share it at the end of the lecture. I'll ask Sami to do that for us. So those people who are asking which group, so the group is basically for our students who are enrolled in the course. I understand a few of you might not be enrolled. So yeah, I think you might have to gain benefit from the live class today. How to join, I'll talk about it at the end of the lecture. I talk about that in detail. Otherwise, if you want information just now, maybe text Samir, the one who sent you the link, and then you can get a bit more information. All right, guys, so let's take that 10-minute break. Okay, so are you guys back? Let's see, a few of you are. Right. I might just wait for 2 more minutes, and then we can start. Have you been finding the session okay so far? Okay. That's good to know. I can see some common names, the same names repeating who've been replying. Not sure about the others. Can't hear. Are you able to hear me okay, the rest of you? So if some of you can hear me, guys who can't, just check your settings, because I guess most of them are able to hear me and they're saying yes. Okay. All right. So I guess we're ready to talk about vasculitis now. Okay, so vasculitis, it's inflammation and necrosis of the blood vessels. It's divided into small, medium, and large types of vasculitis. Now, some of the common small vasculitis are HSP. I think you might have discussed about it either in hematology or in pediatrics, one of these, but we'll briefly go through it in rheumatology as well. Then we have Behçet's disease, we have Church-Strauss syndrome, we have WG, and microscopic polyangiitis. So the medium vessel vasculitis, we have polyarthritis nodosa, and we have Kawasaki disease. And the large vessel ones are giant cell arthritis and Takayasu's arthritis. Okay, so let's start with the first type, which is small vessel vasculitis. And we'll start with HSP. Okay. Now, HSP is the most common type of vasculitis in children, and usually it follows after upper respiratory tract infection or a group A beta hemolytic streptococci tonsillitis or pharyngitis. Now, what are the features of HSP? The most common feature that we'll find is a rash, either on the buttocks or leg. It can sometimes occur on the trunk and arm as well, but a typical one will be on the legs. Then there's arthritis, abdopain, hematuria. So this is what the rash looks like in HSP. In AMC1, you do sometimes get images. So, in rheumatology, we've seen so many images, so many joints involved. So just make yourself familiar with what you're reading, what you're understanding, that when you see that image, you're able to identify those conditions. Okay. Now, what investigation will we do for HSP? We'll do a coagulation profile. Why are we doing a coagulation profile? Because, when we see a new rash, Yeah, when we're seeing hematuria, obviously we will do a coagulation profile to see, is it a bleeding disorder? How is the bleeding time? How is the clotting time? How are the platelets? But in HSP, everything's going to be normal on the coag profile. We will do a urine analysis. Why? Because there's hematuria. So we want to check, is there some infection, or are we seeing something else in the urine sample? So these are some basic tests that we will do. Okay, management, usually HSP is self-resolving. Children get it, and then over some time, it's resolved by itself. But if it's not resolved, and if the patient is in a lot of pain, then we can consider steroids. One complication of HSP is intussusception. So you need to make sure that you have ruled out intussusception before giving steroids. Okay. Besides intussusception, the other complication could be kidney failure. Why is that happening? It's happening because of deposition of IgAs. So that was the first type of small vessel vasculitis. Then the next one we're going to talk about is Behçet's disease. I guess with Behçet's disease, I'm not sure if you guys have read about it in some other topic, but anyway, so Behçet's disease, again, it's a small vessel vasculitis. It's multi-system involvement. Some common things that we're going to see are ulcers. So we're going to get mouth ulcers, which are painful and recurrent. Genital ulcers, we're going to see arthritis. Then pathergy reaction. What that means is that when you get a small prick, it will lead to pustule formation. Then inflammation of the eye. So it can be iritis, uveitis, there can be pain, there could be decrease in vision. Then what else? So this is just a figure. I quite like this figure. You can have a look at what all is affected in Behçet's disease. You're getting ulcers, which are involving the oral cavity and the genitus, uveitis. Obviously, it's a vasculitis, as well as pathergy reaction. Now, before we move forward, I just want to ask you, testing your memory here, oral ulcers, these are painful in Behçet's disease. Can you guys tell me, we have discussed about this earlier, where do we get oral ulcers which are painless? We've already discussed it in the first bit of the presentation. SLE, wonderful. That's amazing. A lot of you have written that. So well done. It's very important to remember these tiny findings in rheumatology, because that's how the questions are going to be framed, because if you think about it, in SLE, there is eye involvement, there is ocular involvement. Okay, so it's very easy for them to frame a question that, okay, so and so female comes in with uveitis or something and some oral ulcers which are painful or which are painless. So the only point which might help you in finding the correct answer is if you know that where are we getting these painful ulcers and where are we getting these painless ulcers. So such points, just make sure you remember them. Okay. Okay, now management of Behçet's disease is high dose of steroids. We need to treat ulcers. You can give some immunosuppressive drugs. I think I've spoken a lot for one night. Okay, so you can give some immunosuppressive drugs. You have to refer to an ophthalmologist as soon as possible. Why? Because one complication with Behçet's disease is blindness. So that's why you need to refer. The other complication could be colitis. The third one is thrombosis. I think the one that AMC test is blindness, and they test referral to ophthalmologist. So you should know the others as well, but I'm just telling you that this is one thing that has previously been tested on AMC1. Okay. Now, let's go on to the third type of small vessel vasculitis. These are three that are remaining. These are all ANCA-associated vasculitis. Bear in mind, we are still in the small vessel vasculitis. But the commonality in these three is that they're all ANCA positive. Okay, so the first one is Wegener's granulomatosis. That's WG. Okay, so what are the clinical findings? So with WG, you're going to get upper respiratory tract like symptoms as well as lower respiratory tract like symptoms. So if it's upper respiratory, you're going to get things like sinusitis, rhinitis. Lower respiratory is more like pneumonia. Okay, you're going to get oral ulcers here. You're going to get polyarthritis, sometimes some eye symptoms as well. Sometimes there's kidney involvement in the form of glomerulonephritis, and then finally CKD. But how will you diagnose WG based on the clinical history? It's going to be upper and lower respiratory tract infections together. Okay. Yep, so this figure is showing the same thing, that we've got our sinuses involved, as well as we've got the pulmonary parenchyma involved, our alveoli is involved. We've got some kidney involvement as well. So this is a common feature of WG. In terms of investigation, serology-wise, we already discussed that, this is going to be C-ANCA positive. But for confirmatory diagnosis or the most accurate diagnosis, we need a lung biopsy. And if we look at an X-ray, we're going to see some pulmonary nodules, which are like granuloma type. We might see some infiltrates or some cavitating lesions. Okay. Now, the second ANCA-positive vasculitis is Churg-Strauss, which is also known as eosinophilic granulomatosis with polyangiitis. It's called this because we see lots of eosinophils on our blood picture. So it's almost like WG. The only difference will be that it'll be more like an asthma-like clinical presentation. Eosinophils are going to be high. And the difference is that P-ANCA is going to be high here. Okay. In terms of treatment, we can give some steroids and we can give cyclophosphamide to treat this condition. Okay, now we're going to move on to medium-sized vasculitis, which is polyarthritis nodosa and Kawasaki disease. Polyarthritis nodosa is quite commonly tested in AMC1. I think they test this the most from what I recall. So it's a necrotizing vasculitis which leads to skin nodules and ulcers. It's a common risk factor that you can see with PAN. It's more common in drug abusers, people who have a background history of B-cell lymphomas, and people who have previously been hepatitis B positive or are currently Hep B positive. Okay, now in terms of clinical features, these patients will be generally fatigued, just having weight loss, feeling unwell. We could get some skin ulcers. We could get these features called levido reticularis on the skin. There could be nerve involvement causing foot drop. There could be kidney impairment, hypertension. These are some common clinical features in PAN. This picture over here shows how libido reticularis actually looks like. And this lovely image here. So when we do, share the slides with you for people who are enrolled in our group, I think the slides will be helpful later for your revision, because you can have a look at the image and that helps you retain the information a bit more better. All right, in terms of investigation, for PAN, ESR would be elevated. Confirmatory diagnosis would come again either by biopsy or angiogram, if that is one of the options available. And management would be steroids again for PAN. Okay. Next up, we have large vessel arthritis. So we have giant cell arthritis and Takayasu's arthritis. So let's talk about this. Temporal arthritis, giant cell arthritis. So clinical features would be headache. Now the headache is going to be unilateral, constant. It's going to be progressive in nature, thrombing kind of headache. Sometimes these patients will complain of intermittent blurred vision. Eventually it could lead to blindness. Then there's going to be loss of sensation of temporal artery. There'll be tenderness when you palpate these patients on the temporal area. There could be jaw claudication. So these are some common features of temporal arthritis. All right. PMR. So PMR, it's a disease of elderly. Mostly these patients are going to be more than 60 years of age. Common features would be pain and stiffness in the proximal muscles, mostly the shoulder and the pelvic girdle. Okay, it's going to be a symmetrical distribution. The patient will have similar complaints, like polymyositis, that not able to comb hair, not able to get up from a sitting position. Now, in terms of treatment, because we discussed that temporal arthritis, there can be a complication of blindness. So we need to give high dose of prednisolone, like around 60 milligram, in order to prevent that. And we need to give aspirin along with the prednisolone. But if it's just PMR, so in PMR, we can give a low dose of prednisolone. We don't need to give 60 milligram. And then we can taper it, over some period of time based on how the inflammatory markers are. But the point to remember for your AMC exam is that temporal arthritis, it's high dose of prednisolone. If it's only PMR, you can give low dose of prednisolone. Okay, the next large vessel vasculitis. So we're going to talk about Takayasu's arthritis. Okay, now the arteries that are commonly involved in Takayasu's is actually the aortic arch, and Takayasu's is more commonly seen in the younger section of population, unlike the previous vasculitis. So it's more common in younger females and more commonly seen in Japanese females. The clinical feature would be we have absent peripheral pulse, hence it's also called like a pulseless disease, and there'll be hypertension. In terms of treatment, the treatment is going to be steroids, or we can give some medications like methotrexate or azathioprine. Okay, so see, in terms of vasculitis, what they're going to ask you is most likely to diagnose based on what clinical features there, based on what arteries are affected. It's going to be diagnosis kind of questions mostly. Okay, now I've got the next slide, which is giving a summary of the serological tests that are positive in different conditions. So you guys have a look at this. SLE, we've already discussed that ANA will be positive. It's positive in a lot of other conditions. So it's not a specific test. But anti-dsDNA and anti-Smith, these are the ones which are more specific for SLE. Then antiphospholipid syndrome, we're going to have definitely antiphospholipid antibodies, which are going to be positive, but the more specific ones are anticardiolipin and anti-beta-2 GP1 antibodies. Now for scleroderma, we're going to have anticentromere positive. This is more associated with CREST syndrome, and anti-topoisomerase is associated with systemic sclerosis as such. Now, Sjogren's, ANA definitely will be positive, but it's anti-Rho and anti-lambda that we need to be looking at. Okay, now WG-C ANCA is positive, and Churg-Strauch is P ANCA positive. Before moving forward, can you guys tell me what would be the main differentiating feature between WG and Churg-Strauch based on the history? Come on, guys. We just discussed about it. Yeah, that's good. That's good. Very good. A lot of you are writing eosinophils, asthma. So that's going to be one differentiating component between these two conditions. That's WG and jerk strokes. Okay. Well done. Okay. So some of you might be very confident in rheumatology because you have gone through it a couple of times, but for those who find this topic difficult, I'll say that the more you revise and the more you try to categorize these conditions, make categories that these conditions have some commonality, and then find out the pinpoint differences between them. In that way, you'll make a link clinically, so it'll become more easier for you to remember those things, and it'll become more easier for you to apply it in clinical setting. That's what worked for me, and I think it might be helpful for you too. Okay, now I've got some questions. Actually, I've got 3 questions, and it's something that we have not discussed in this slide, but I noticed that this question was asked in the exams. I've put that question up. We'll discuss about that. But I wanted to know if you guys quickly want to go through what we have done, like, just the most important points so that it sticks in your head today in the class. And when you revise, then it's just like a second revision for you and you remember it for good. So if you want to do that, we can do it now. Or we could go ahead with the question. Okay, Bhavna, is that yes for a quick revision? Okay, guys, I'm a bit confused. Are you guys saying yes because you want to do a quick revision, or? Okay. All right, let me go back to the first slide and we'll just do everything very quickly, like in 5, how much time we have? We have half an hour. So in 5 to 10 minutes, so it'll stick in your head for good, And when we do the questions, maybe you guys know the answer already. Okay, let's start. I want you to work with me, make sure that your brain is working as we go along. So first thing we learned about was OA. The main thing for you to remember in OA, it's a wear and tear disease. It's going to be more when the patient exercises more. It's going to be less with rest. Morning stiffness, not going to be there. So these are the main things that you're going to remember. It affects all the joints of the hands, including the DIP. Okay. Now, what else are you going to remember? X-ray of osteoarthritis. That's something that they will test you on. So what are you going to see on the X-ray? You're going to see sclerosis. You're going to see osteophytes. You're going to see decreased space, the decreased joint space. So let me get that image up. Okay, that image. So remember that image and you'll be able to remember what you're going to see on the X-ray. All right, next up, treatment, paracetamol, regular paracetamol. Okay, next up was RA. So RA is inflammatory. Inflammatory means it's going to be more at rest. It's going to be relieved with exercise. Morning stiffness is going to be there. All right. Then symmetrical joint involvement. Hands, it will affect your proximal interphalangeal. It will affect your metacarpophalangeal and your carpometacarpal. It will not affect your DIP. Not affect your DIP. Remember that. They will test you on that. Okay. Now I'm going to talk about deformities in revision. Now, rheumatoid factor will be positive. Anti-CCP will be positive. Anti-CCP is more specific. Okay, X-ray, what are we going to see in X-ray? We're going to see erosions. We are going to see subluxation. We're going to see deformities. We're not going to see sclerosis. We're not going to see osteophytes. Okay, We've discussed this already. Treatment, early DMARDs is the treatment. Okay. Now, next we talk about ankylosing spondylitis. So that again, inflammatory, but RF will be negative. HLA-B27 will be positive. What else is affected? Tendons are affected. Okay, so it's going to be plantar fasciitis. What else will you get? So it's mostly low back pain. So chest expansion is going to be less. Lumbar, bending down is going to be less. What else? Morning stiffness will be there. Why? Because it's inflammatory. I am actually going through the chat box as well, guys, and well done that you guys are writing down. It makes me believe that you guys are using your brain as well. So it's a good revision if you are going through it along with me. Okay. Poor prognosis, younger patient, hip involvement, not relieved by NSAIDs, whole finger involvement like dactylitis. These are some poor prognosis factor. On X-ray, what are we going to see? Bamboo spine. What's the most accurate test? It's going to be MRI. Okay. Treatment, NSAIDs, DMARDs, methotrexate, and steroids not going to work with AS. Next, we talked about reactive arthritis. Reactive arthritis is can't see, can't pee, can't climb a tree. Remember that, you'll be able to diagnose it. Treatment, NSAIDs, and DMARDs. Now, psoriatic, it's again inflammatory arthritis, but affects your nails, affects your fingers. Affects your nails, affects your skin. Treatment, again, NSAIDs and DMARDs. Now, crystal disease, gout. Gout, crystal deposition. What crystal is deposited? Monosodium urate. This is going to be an acute setting, very painful, very tender, affects the big toe. Risk factors, anything that increases cell turnover, anything that decreases uric acid excretion. Foods like, red meat, alcohol, smoking, conditions like diabetes, hypertension. Okay. Now, investigation. So uric acid will be high. It's going to be needle-shaped crystals on the synovial fluid, negatively birefringent. Treatment, if it's an acute case, then it's going to be NSAIDs. Okay. Now, in between attack, you're going to use allopurinol. And for tophi, again, it's going to be allopurinol. Pseudogout, it's like gout, but here we have CVB crystals. Okay. Pseudogout, more likely to affect old people, osteoarthritic bones. What will you see on the synovial fluid? You'll see rhomboid crystals, and these are positively birefringent. All right. Guys, are you still with me? I shouldn't be the only one who's going through rapid revisions. Yes, that's good. One person is with me. Okay, a few. That's good. Next. So connective tissue disorders. The first one we talked about was SLE. SLE, most common connective tissue disorder, affects a lot of organs. What are we going to remember? We're going to remember the malar rash. We're going to remember discoid rash. We're going to remember painless oral ulcers. We're going to remember serositis. Okay. We're going to remember kidney involvement, sometimes CNS involvement. Now, investigation. ANA will be high, anti-dsDNA, anti-Smith, more specific. Most accurate diagnosis, skin biopsy. Treatment, mild, moderate, severe. If it's only bones, NSAIDs. If it's bones and skin, hydroxychloroquine. If it's beyond that, then steroids and methotrexate. Scleroderma, we talked about Kress syndrome. We talked about some common findings like tightness of the skin, stretching of the skin. So it causes bird-like faces. It causes, Roman breastplate. Then Kress syndrome, this figure helps us with Kress syndrome. Okay, remember those pictures of calcinosis. Remember this picture of sausage-like fingers. Remember the telangiectasis. Somebody is asking malar flush is seen in SLE. That's correct. Okay. Investigation, serology, specific ones are going to be anti-topoisomerase and anti-centromere. Remember C and C. If it's Crest syndrome, it's going to be anti-centromere. Skin biopsy will be the most accurate. Okay. Then Raynaud's phenomena, calcium channel blockers, stop smoking. Now, Sjogren's syndrome. Sjogren's syndrome, it's more common in people who have non-Hodgkin's lymphoma. What are the clinical features? Dryness, everything. Okay. Now, what is the investigation? Anti-Rho and anti-lambda. Antiphospholipid. Antiphospholipid syndrome is clots. Either it's thromboembolism or it's pregnancy-related complication. What is the serology? So in serology, definitely we are going to get antiphospholipid antibodies, but the specific ones are anticardiolipin, anti-beta-2, GP1. Treatment, aspirin. But for thromboembolic, warfarin. Myositis, if it's just dermato, it is skin. If it's poly, it is muscle. In dermatomyositis, we're going to get these violet color rashes or papules. And in polymyositis, it's proximal muscle involvement. Investigation, muscle biopsy is confirmatory. Vasculitis, we divided it into three. Small, medium, and large. Okay. Now, what are we going to remember in HSP? We're going to remember that rash, the picture that we looked at, rash on the buttocks and legs. We're going to remember hematuria, more common in children. Complication, intussusception, and kidney failure. Okay. Behçet's disease, we are going to remember multi-system involvement. Yes, it's going to be oral ulcers, which are painful, genital ulcers, arthritis, and eye involvement. Okay. Then we're going to WG. WG, we are going to remember it affects your upper and lower respiratory tract. So this is the most important thing in this. Then next, investigation in WG, C ANCA positive. In Church-Strauss, asthma-like. It's just like WG, but asthma-like, and it's P ANCA positive. So how we remember this? Church-Strauss starts with a C, but it's P ANCA positive, and WG is C ANCA positive. Okay, next. So we have PAN. In PAN, we need to remember it's more common in those who... Oh, somebody's asking why she's reading slides. I don't know if you were here before, but we've already gone through everything and we are doing a quick revision now. So try to catch up, Dhruv. Okay, PAN, associated with drug abusers, B-cell lymphomas, hepatitis B antigen. Okay, now this is a livedoreticularis image that you can see here, and polyarthritis nodosa image that you can use later. Okay, next. Confirmatory is going to be biopsy. And giant cell arthritis, temporal arthritis, what did we learn here? What was the most important thing? We learned that it's going to be unilateral headache, there could be blurring of vision, there's a complication that may lead to blindness. So what did we learn about treatment? We learned that we need to give high dose of steroids. But if it's only PMR, then we learned that we can give low dose of steroids. Very good. I like that you guys are replying and working through this with me. This is the best way to learn, I feel. Okay, now we have done this. Ready? Okay, Takayasu's. So Takayasu's, what did we learn here? We learned that it affects the aortic arch, more common in younger females, like most likely Japanese females. And treatment was steroids. So that was a quick revision. It might be quite high dose for some of you, but those who are already preparing for AMC 1 or about to take the exam, I'm sure you guys must be working with me as I quickly went through the slides. And you know that sense of satisfaction when you do that quick revision in 5 minutes, it's like you're double layering your knowledge. So I guess for some of you, it might be good. Okay, so are you guys ready to do those 3 questions now? Okay, that's good. Let's go to the first one. I'll give you a minute to read, and then in the chat box, you can tell me what you think is the right answer. Just write the letter A, B, C, D, or E. I'll just give you a minute, guys. I might drink some water. I spoke too fast. Also, I want to tell you, this is one of the difficult questions, and we didn't discuss this in our teaching today, and that's the reason that I put it as a question, because and if you don't know the answer, it's absolutely okay, because this is a time to not know the answers and understand what the right answer is, so you know for the exam. Okay, so I think a lot of you have answered already. You can say a few E's. Okay, let's have a look at the answer together. So the answer is D. We stop both because there's a chance of infertility. Okay. Yeah. Now let's look at the next question. I think this is something we have discussed about. So take your time and tell me what the answer is over here. Okay. Okay. Few of you are writing the correct answer. Again, if you are getting this wrong, it's okay because we're just learning. Okay. So the correct answer for this one is a C, continue allopurinol and give steroids. Okay, let's look at this. I think this might have been an easy one. So I've put some difficult questions here, okay? It doesn't mean that your entire exam is going to have difficult ones. They're going to have very easy ones, moderate, and a few difficult ones. Okay. I would call this as a moderate one, but I think most of you are writing the correct answer because we just spoke about it. So yes, it is C. Okay, so I'll be winding up the class now. I hope you guys have learned something during the class. Of course, you can go back and go through the slides and your notes. We'll share it with you. But I hope you've learned something even during the class. Just be confident, okay? Keep revising. Make sure you make your own groups and do lots and lots of questions together, because that's one of the better ways to learn as you're closer to the exam. Thank you. I'm glad that you've liked it. Also, because I think I took the first class for you guys. I haven't taught you guys previously. So if you have any feedback, either about today's class or about any other classes, so feel free to mention that on the chat box, because we want to improve for you and we want to make sure that we're doing the right things for you. Okay, so I'll give you a minute. If there's something that you think can be done better, I'll just have a look at the chat box. Oh, I'm glad that you guys liked it. Yeah, we'll try to share the schedule with you. I think we can do that. Yeah. Okay. I think some of you were asking previously that which group and will we get the slides. So I think those are the people who haven't enrolled in our course yet. So for those who are not in our course, we are actually starting a new batch in April. And if you want to join our course, it's for AMC 1. If you're somebody who has, who's thinking about coming to Australia to work as a doctor, just go through some of our YouTube videos, or you can book a session with us if you want more information. And then you can speak to our manager, Samir, on this number to get more details about the course, and you can join our course over here. Okay. And for those people who are already in our course, I hope your preparation is going well. And, I hope you guys have made your little groups where you're discussing questions together. I know that, one of our colleagues shares a lot of questions on the group, and you guys try to answer that very well. So that's well done. And if there's anything else that you want from us, you can let us know. Okay. See, AMC 1, I think it's not a very difficult exam, honestly. If you've given these competitive exams in your home country, AMC 1 is not a difficult exam. It's slightly tricky because we are new to those guidelines. And hopefully through this course, we're going to tell you about the Australian guidelines, and we're going to tell you about the nitty-gritty things that are important in AMC 1. But otherwise, AMC 1, I don't think it's a very difficult exam, honestly. Once you understand what kind of questions they ask, it should be a smooth journey. And if you think about it, you don't need a very high score. You just need to get that cutoff in order to clear AMC 1. Someone is asking, should we complete our internship or better to give AMC 1 simultaneously? See, I think we've made a couple of YouTube videos about this, but then it really depends. If you want to study, while you're working an internship, maybe start studying about AMC and start preparing, and maybe take the exam after your internship. It really depends person to person. So see what works for you. For some people, the internship is super busy and they can't study. For others, it might not be that busy. So you need to decide on that. Oh, thank you. I am glad that a lot of you are saying that the classes have been good. Facing difficulty to be registered. So Neela, if you're facing difficulty, just copy this number that I have on the slide. That's Samir's number, and he can help you to get registered. What are the job offers after AMC 1 nowadays? Do they need experience? Um, Okay, so there is an option that you can apply at the level of an intern if you don't have any experience before and you haven't done internship. But intern jobs are a bit more difficult. If you want a more detailed discussion, you can book a session and we can discuss with you based on what all you have done so far, what is your experience, and what would be the best approach for you to move forward with the AMC journey. You're most welcome. I'm so happy that you guys liked the session. Is there anything else that you wanted to know about the exam or about the course or any other issues that you're having with the course? Oh, thank you guys. I really enjoy teaching this myself, and it's been so good because you were so interactive and you were always replying when I was asking a question. So it was a wonderful experience for me too. All right. Um, what they expect from us in PGY1 should be perfect in fixing cannulas. Um, okay, so I'll answer that. So yes, they expect a junior doctor to know how to insert cannulas. It's quite funny. Like I did my med school in India and we didn't have to do a lot of cannulations there. But here in Australia, almost all the hospitals, doctors are the ones who are supposed to learn how to do cannulas, supposed to do all the cannulas. So if in your med school, medical students or interns are not supposed to do cannulas, just try to learn in med school. So when you do come here, it's not that difficult for you. Yeah. Everybody hates cannulas, but you have to do it. It's very important. Okay, you're most welcome, guys. Just 1 or 2 more minutes to go. If there's anything related to the course or about AMC1 that you want to know. Subjects asked in AMC1. Although it says clinical subjects, but all subjects are covered in AMC1, you get questions from pharmacology as well. So have a look at their website and see how the division is. Otherwise, we have videos about that too on our channel, about how much is asked from medicine and how much from surgery. But, when you start doing questions, you'll get an idea as to what is usually asked, what topics do they like more. So you need to do questions and maybe start learning the study material, and that'll give you a better idea on what's covered and what's not. With internship, can we get a job in AMC1 or do we need to do AMC2 too? This can be a very long topic of discussion. I think we've had webinars about AMC1 previously, and we might do one again. So maybe try to join those webinars if you want to know more about the logistics of AMC and getting jobs and everything. I don't think this is the right time to discuss about that. Okay, guys. Okay, so it was lovely discussing rheumatology with you all. I hope there's something that you've taken away from the lecture, and hopefully I'll see you guys again very soon with another topic. All right, you all have a good evening. See you. Thank you.